this working?
Yeah.
Thank you. Thank you for coming in early. I picked the earliest spot because I figured you wouldn't be asleep yet. And my lecture is very short, so we might be gaining time just because I timed it and it's going to be about 30, 40 minutes. It's going to be perfect. Burning mouth is something I see on a routine basis, and you probably see too. This lecture is meant to be very practical. It's kind of like a step 1, step 2, step 3 to work up a patient that presents with burning mouth. So hopefully you can integrate the information that I'm going to give you directly into your practice. There's no need to take notes. The presentation will be emailed to you by Shadlin after the lecture. So as long as she has your email, you will get a copy of the whole thing. Okay? So to start with, I don't know how many of you have seen patients with burning mouth, but it's relatively a uncommon disorder, which means that I have seen many patients with burning mouth disease. It's not necessarily a weekly occurrence, but it's probably a monthly occurrence in my practice. So how many of you have seen people who present with burning mouth? So that's pretty representative. I've seen articles that claim that even talk about 17% occurrence, which is a little bit high. I think this is probably more accurate in terms of percentage. But if you look at the increased risk and the comorbidity, I mean, this is pretty much everybody over 50. So more common in women, more common in the elderly, with an increased risk of upper respiratory infection, recent dental procedure, food allergy, traumatic life event. I mean, that is pretty broad in general. I don't think that it's something that you can say, oh, this person has had these, so they're more at risk. So I kind of discount the last paragraph because it's a little too general. So basically, there is no risk factor that is predominant other than age. I have never seen a person with burning mouth that was really young in my practice, but I'm not saying that it cannot happen.
When you say polypharmacy, is it too many drugs?
Yes. As you get older, you see people with more medication, so it's kind of obvious. So how do they present? They present with burning. The burning can be anywhere in the mouth, so it can be the lips, the tongue, the palate, the gingiva. They can also present with a sensation of dry mouth, which may be more significant to them than actually the burning. And that might be why they come to the office. I had a patient even 2 weeks ago, 3 weeks ago, that came in with ropey saliva that was going through her teeth and entrapping her mouth, entrapping her tongue. And I look at her mouth and the saliva is normal, completely normal, fluid, but she perceived it as this ropey, entrapping, abnormal type of saliva. And she also had burning, but the burning was, she didn't care about the burning, she cared about the saliva. Taste change is very common. Some people have decrease in taste, some people have downright forte and bad taste. Metallic is very common. More common than bitter, probably. And the interesting thing is that it can move from the right to the left, or from the tongue to the palate, from one week to the other. So it seems like a little odd in terms of a symptom. And the tongue looks absolutely normal. That's one of the things that is bizarre to the patients, that they have a burning and yet the tongue is completely normal. And sometimes they grasp on certain things, and you look at the bumps on the side of my tongue, but the bumps are completely normal as well, but they just never notice them. Or they look at their tori, and they say, oh, this is probably what it is for. And again, it's not what it is, but patients like to grasp something physical that they can see. And part of the disturbing aspect of this disease is that they cannot see anything. And nobody can see anything. The dentist cannot see anything, I cannot see anything. So it's one of the distress etiology, and I'm going to have you read two paragraphs. One of them is from 1991, and this is the one from 1991. Pretty relevant here is assumed to be a functional disorder because it responds to mood-altering drugs. And so this is from 2012. It looks pretty different, doesn't it? I mean, in here it's like, okay, this woman is crazy. And in here it's pretty neuropathic. So evidently there has been a lot of research done on this disorder, and there's still a lot of things we do not know. But the consensus is that it is a neuropathic disorder. And the fact that it involves mostly women over 50 probably contributed to this type of etiology initially. Similar to fibromyalgia. Fibromyalgia initially, people thought it was kind of a psychological disorder affecting women. But now we know that it has a neuropathic origin and that it's not at all something that happens in crazy people. And the same thing with burning mouth disorder. So anytime we cannot see anything, we get the bad rap. If it affects women and you cannot see anything, so when you get a patient, the one thing that you can do is determine whether it is a primary burning mouth syndrome or a secondary burning mouth disorder, because that is going to be how you're going to treat those patients. If it's a secondary, then you just treat the primary cause, and theoretically the burning should disappear. So what is the workup for a patient who presents with burning mouth syndrome? There are a lot of things you can do. A lot of testing, a lot of screening. As you can see, there are lots and lots of reasons why patients can present with burning mouth. The most common one would probably be Candida. And that sometimes you can see, and sometimes you cannot really see. You have to send them for a test, for a swab. I don't do those in my office. I send them to an oral medicine specialist in Mountain View. But the rest of it you can pretty much gather from either their medical history or a blood test will give you the vitamin deficiencies. If one of them is positive, you make sure that is under control. Have the patient come back when the disorder has been resolved, and if they still have burning mouth, then you start thinking, okay, it's probably idiopathic or primary burning mouth syndrome. The one thing that is interesting is this, because sometimes patients don't know that they are thrusting their teeth against their tongue against their teeth, but you can actually observe them, and you can ask them if they play with their teeth, with their tongue, because they usually are not aware of this. So I had a couple patients, and the tip of their tongue, when it's at the tip of the tongue, when the burning is at the tip of the tongue, you really have to be aware that this can happen. And it's of course very difficult to treat because it's a habit. Do you have any questions on this? Yes. Do you have any questions on the test, on the diagnostic test?
Would you start them on multivitamins first, or how does that work?
No, I actually have them do a blood test to check for deficiencies. And if there are no deficiencies, I don't bother. This is not that common. Most people don't have really severe vitamin deficiencies unless they have comorbid diseases that cause them to happen. I mean, this is also interesting because you cannot You can have no symptoms of GERD, and so GERD doesn't necessarily have to appear in the medical history, but you can ask them specific questions like you sometimes have, if people have silent reflux, they sometimes will have occasional GERD. They're not diagnosed with GERD, but they sometimes have like a stomach upset or gastritis or sore throat if they have a small cough. They have a dry cough, if they have hoarse voice. Sometimes they will have silent reflux that is not painful. I don't know if I would go to the length of getting an endoscopy to see if they have silent reflux, but it's something that you can keep in mind. So the treatment obviously the treatment for somebody who presents with any of these would be to address the deficiencies and those comorbidities first. Then we have the treatment, if everything checks out normal, the treatment for burning mouth syndrome, the gold standard is clonazepam in combination with gabapentin. It used to be, a few years ago when I was in training, we used to only use clonazepam. Now the recent research has shown that if you use clonazepam with gabapentin, the treatment is more effective. Now I don't know if you have any personal experience with clonazepam and gabapentin, but they have considerable side effects. And so it's a tough sell for patients to take. So I have started using as well rinses where they can rinse and spit out the clonazepam so they don't get as much systemic effects. The sublingual is good because at lower doses the clonazepam can stay in contact with the mucosa longer, so they can get better results at lower doses. And with gabapentin, I have started experimenting with different formulation, which is Release, which is an extended release gabapentin, which, according to the studies, has a lot less side effects because it has a constant level in the blood. It doesn't have the peaks and valleys, so less sedation than gabapentin does have. I don't have much personal experience. I just started using it, and actually you're going to hear, hopefully, a case where the patient was prescribed gabapentin in the form of Release this afternoon. So I cannot tell you firsthand if my patients like Release better than gabapentin at this point. Lyrica, which is a precursor of gabapentin, pregabalin, also carries less side effects, but sometimes it comes to a financial decision. Gabapentin is very cheap. Lyrica is very expensive, and Release is even more expensive because it's a newer medication. So for some patients, there is no choice but gabapentin. Clonazepam is fairly well tolerated at low doses. I start them with 0.25 and then I increase them, always giving the highest dose in the evening since it's sedating. The last two I don't really use, but I know that the UCSF oral medicine department uses it. Chlordiazepoxide is Librium, which is very addicting, much more addicting than clonazepam, and so I really don't like to use it. But I know they use it down there, so I put it in, but I have no personal experience for it. We did not use it at UCLA. And amitriptyline, same thing. I really don't like amitriptyline because it has considerable side effects. Patients hate it, and the compliance is very low because of the side effects. So I may use a different tricyclic antidepressant that has less side effects. But amitriptyline, I don't think that I've had a single patient who's stuck with it. They have tremendous dry mouth. Dry mouth is very, very, very severe. While nortriptyline, desipramine, the dry mouth is not quite as high. Do you have any questions on the treatment?
Just a general
Yes.
question about gabapentin. I'm finding more and more patients